All right, welcome, June 17th. Uh, welcome, Candice, Sonny, Simon. You can get started whenever you're ready.
Okay, all right. So question, when using headgear and elastics for a significant class 3 patient, when within the care plan, do you recommend starting each therapy? Do you expand for a certain amount of time to adjust and elastics, then headgear? Or do you recommend evening headgear, daytime elastics at the same time, or we start to expand the plates? Um, so this is a general question, but each case is different depending on whether it's a high angle or a low angle case, and depending on whether we're starting in primary dentition, mixed dentition. Um, we have to make space, level and align, and then do mechanics. So that's basically the orthodontic process, and that's also how we apply the sequence of treatment to early intervention. So creating space, flattening the curve of Wilson and Spee, and then applying mechanics. In that order. So apply plates go in first, and we make space. And we see if the space is sufficient uh, to improve the bite relationship. If it isn't, after we've done our arch development and reduced the curve of Wilson and Spee and flattened everything out, then AP correction begins. And AP correction is done through the use of either extraoral traction on the maxilla and inhibition of the mandible through the face mask action, or interarch elastics. So when do you choose one? When do you choose the other? Depends on if you are deficient in the maxilla or excessive in the mandible. So if you're deficient in the maxilla, then you want to pull on the maxilla because your mandible is relatively normal. If you're excessive in the mandible, then you want to hold the mandible and pull on the maxilla. So if you're just pulling on the maxilla and you don't want to do too much of the mandible, then you just use the face mask. If you are trying to manage an excessive mandible and insufficient maxilla, then you do both. You do extraoral traction with the headgear and you do interarch elastics. Normally, we wear the interarch elastics during the day and the face mask at home and at night. So that's generally the sequence. You make transverse width for anterior space. You level the incisor relationship with the cat wires, occasionally using limited fixed braces if you have excessive curve of Spee. Then you make a decision based on your initial diagnosis of whether it's an excessive mandible and insufficient maxilla, or a normal mandible and insufficient maxilla, or excessive mandible and normal maxilla. You will then go to face mask at night and at home during the day. And if you're going to use interarch elastics, then you will use that during the day. Why would you choose interarch elastics versus extraoral traction? If your imbalance is dental, then interarch elastics is the choice. If your AP discrepancy is skeletal, then extraoral traction. If it's both, then you use both. All right, next question. Will you help me understand what weight of elastics you recommend, especially for a 4 or 5-year-old? Do they differ between age groups? If we're talking extraoral traction with the reversible headgear, they're very young at 8-ounce elastics. There's only 2 grades of extraoral elastics, 8-ounce and 16-ounce. So we want to try to use 16-ounce. But if they're very young, you might start off with 8-ounce, build up to it. Depends on how good your retention is on the plates. Theoretically, you want to get to 16-ounce for everyone, and your plate should hold if you have good design and retention, resistance form. Intraoral elastics, you can use the 1/4 inch. You can use 4.5 ounce, 6.5 ounce. Just depends on how big or small the patient is. Okay. If you want extra pull, you just shorten the elastics. You might use 3/16, 6.5 ounce. Just depends on how retentive the appliance is. If you can't get it retentive enough to use a heavier elastic, it's better to use a lighter elastic more often, and at least you get something out of it. Obviously, the older the patient, the bigger their arch form is, and the bigger the distance between your elastic pull. So it's, to some degree, it's just find something that works for each patient. And usually interarch elastics is around that 1/4 inch, 3/16 inch. And the pull force is about 4.5 to 6.5. Try lighter. Okay, so next question. Will you help me understand how the bowl-shaped curve of Spee developed for children, dips in the premolars and rises in the mandibular and anteriors? When I review reading the face article, I don't see that mentioned. So reading the face is John Muir's article, and he's not particularly interested in teeth. He's only interested in the face. So he doesn't go into orthodontic terms. Curve of Spee is a dental arch description and is a term that is used in restorative dentistry, in rehabilitation, restorative dentistry, uh, in uh, denture dentistry, in orthodontics. So the curve of Spee pertains to the shape of the arch form. Um, if you're ever in need, Google is your friend. All right, that's the curve of Spee. So do with this curvature. And it's the relationship from the molar to the incisor tips. Just trying to figure out how flat the plane is versus how curved the plane is. So the flatter the plane, the less the curve of Spee is. The steeper the plane, the bigger the curve of Spee. So it's to do with that plane. Right, so how does that develop and how is that impactful? So this would be a very steep curve of Spee where there's a big dip, where the incisors are at a significantly higher plane than the premolars or the molars. And then this would be a relatively flat curve of Spee. So that's flat. And that's steep. So how does that develop? A steep curve of Spee is usually related to the tongue living in this black space. Tongue sits between the molars, kind of flowing over the sides, and doesn't quite touch the incisors. And the patient rests with a freeway space. So what tends to happen is the tongue becomes the occlusal stop for the opposing teeth, and the teeth erupt into the tongue, and then they stop, and the tongue lives in that space. But because the tongue tip in these patients don't touch the incisors, and the patient rests with the freeway space, the incisors are unopposed, and so they continue to erupt. And that's why you have a steep curve of Spee, why you have a big distance between where the molars are and the premolars and where the incisors are. So it develops through resting with the teeth apart and the tongue between the molars. In this case, where the back molar and the incisors are on the same plane, the tongue rests in the middle. And in other cases where you have the molars and the premolars in one plane and the incisors in a different plane, and the tongue rests between all those teeth. And the incisors continue to run. Who would normally have a flat occlusal plane? People who rest with their teeth together and are relatively heavy on the bite, so that the tongue never lives between the teeth, and the teeth are in contact, so they erupt into each other. Why do we try to eliminate the curve of Spee? So in restorative dentistry, we don't eliminate the curve of Spee. The natural bite relationship has a small curvature to it. In orthodontics, we try to eliminate the curve of Spee. We flatten it out in order to facilitate mechanics, sliding mechanics. When you have a flat curve of Spee, you can shuffle the teeth back and forth so that they can be moved from class 3 to class 1 or class 2 to class 3. When you have a steep curve of Spee, you only have one bite relationship that works, and it's generally either a class 2 or a class 3 relationship. Okay, it can never be a class 1 relationship, and you can't shuffle teeth or the jaws around in order to achieve a stable bite other than in full class 2 or full class 3. So the steeper the curve for Spee, the more locked you are into either class 2 or class 3 relationship. So class 2 relationship where the incisors on the top are in front of the lower incisors, or class 3 where the lower incisors are in front of the upper incisors. So in orthodontics, when we want to be able to slide the bottom jaw or top jaw back and forth, we have to have a flat plane because a flat plane facilitates sliding mechanics. The other dimension of interest is this curve of Wilson. And curve of Wilson is the amount of tip there is in the molars. Again, the same scenario. In natural dentitions, you have a mild curve of Wilson. But if you want to be able to facilitate sliding mechanics, you have to flatten the curve of Spee and flatten the curve of Wilson so that you can shuffle your teeth or your jaws, if it's surgically your jaws, or in functional appliances, your jaws, or in dental compensations, you can shuffle the teeth in the dental alveolar bone when you have a flat curve of Wilson and a flat curve of Spee. Why do some people have a steep curve of Wilson? Same scenario if the tongue sits between the molars. So if it sits half the occlusal plane, then you have a steeper curve of Wilson. If it flows over to the buccal side, then you'll have a flatter curve of Wilson. It's just the teeth adapt to allow your natural resting posture. So this one. Curve of Wilson. Curve Spee. All right, so lots and lots and lots and lots and lots and lots of information. Why should we care? A deep curve of Spee is commonly associated with increased overbite as a key diagnostic finishing target. Leveling of the curve of Spee is achieved by balancing incisor intrusion and or posterior extrusion while protecting the vertical anchorage, respecting the patient's vertical pattern. Gerber-Wilson reflects posterior buccolingual inclination torque and influences intercustation, transverse stability, and crossbite tendency. Over-flattening either curve can compromise guidance and cusp-fossa relationship, aiming for functional harmony, not a rule of flat plane. So you'd have to flatten it to a degree to facilitate sliding mechanics, but you don't want to flatten it completely so that you can get a socked-in bite relationship. How does it develop? As I said, it's where the tongue rests, whether it rests between the teeth, partly on top of the teeth, fully on top of the teeth, and depends on the amount of freeway space, and it also depends on the lip competency. Okay, so that's Wilson Curtis-Bay. So Steve Curtis-Bay can be class 2, typically division 2, or class 3, typically low angle. All right, so that's those 3 questions answered. All right, any other questions from anyone there?
See if is Candace, Kevin, Sony, do you guys want to unmute? Any questions for Simon? If you want to raise your hand, I can allow you to talk. Just type yes or no. Oh yes, Kevin wants to allow him to talk. Kevin is joining.
Hi, Simon, and thanks, Jan. My question is in regards to a patient in treatment right now. We started before the sixes erupted. Now they are starting to come through. The design of the appliance had a distal saddle, more prominently on the lower. I guess that's where I've adjusted it to make space for the erupting six. My question is in regards to the retention of the appliance. My understanding was that I took away distal saddle acrylic, that I would lose retention. And fortunately, to this point, that has not been the case. But I wanted to get your take on that, Simon, if you would.
So if you're in a primary dentition without 6-year-old molars, you have to make a decision about your design. And if you design for retention and resistance, you can either clasp the D and have a rest on the E as your resistance form and retention form being the D. Or you can clasp the E and then you have to have a free end saddle as your resistance form. If you clasp the D and you have the rest on the E, then the distal acrylic is only there to ensure you expand the unerupted 6-year-old molar with your transverse screw activation. So it won't affect your retention as the 6 comes through. and it won't affect your resistance form as the 6 comes through. If you clasp the E, then you're relying on the free end saddle as your resistance form, and you will then need to cover over the unerupted 6-year-old molar on the retromolar ridge area to act as your resistance form. When the 6-year-old molar comes through, you've got to clear away that cover until you have the sufficient freedom for that 6-year-old molar to erupt. Your clearance will continue all on the occlusal surfaces until you're only engaging the lingual surfaces. And then you will lose resistance form because there's nothing stopping the tipping effect in AP. Because prior to that, your resistance form was the free end saddle loading vertically. When you clear away the cover of acrylic for the erupting 6, then you will lose that. In addition, as the 6 erupts, you want the 6 to erupt into contact with the E. And if you have clasped the E, then your clasp will usually run and block that 6-year-old molar. So you're going to have to trim away the clasp. And that's why you lose retention if you have clasped the E's, because you have to trim the clasp away to allow the 6-year-old molar to erupt into its correct position. All right, so that's why you might lose retention. You lose resistance form because you got to clear away the occlusal coverage of acrylic on the free end saddle. And then as the 6 erupts, you have to clear away the clasp, the distal clasp of that E, and that's why you will lose your retention form. So that's the reason.
Okay. Thank you.
So you might not lose your retention resistance form at the beginning of the eruption phase, but you will lose it as the tooth begins to move into its correct occlusal position.
This will be the case that I present this weekend, so we can dig in a little bit more then.
Yep, so that's the reason. Because you have changing dynamics of a tooth erupting into a place where you have your appliance bits and bobs.
Thank you.
Okay, any other questions? I think Candace said nothing for now. Sonny? Sonny? Kevin, any other questions while you're on the panel?
None right now for me. Thank you.
All right. Sonny says nope. We're good. Thanks, Simon. Thanks, everyone. Until next time.
Bye-bye.
Cheers. Bye.
Good night.